Buenas tardes, muchas gracias por la invitación al amigos ecuadoreño. Sorry, but the Spanish is bad, and so I speak in English. The topic of my presentation will be the superior capsular reconstruction with the biceps tendon. So the topics will be the superior capsular reconstruction with the biceps tendon. And as I said before, La Garcha, we have a different option treatment for the massive rotator cuff tear. And obviously, if we have arthritis, the reverse total shoulder arthroplasty is the elective indication. If we have a patient without arthritis, the superior capsular reconstruction may be an option. The rationale of this technique was described initially by an idea of Teresa Miata, which the aim to restore superior glenohumeral stability and function in the shoulder affected by irreparable rotator cuff tear. The original technique that he described was with the use of fascia lata that was attached medially to the superior glenoid and laterally to the greater tuberosity. This is an important aspect because if you fix the fascia lata to fill the gap between the tendon, so you fix the fascia to the tendon and to the greater tuberosity, from a biomechanical point of view, will fail. Obviously, the first publication in literature are from the authors of this technique, and he published the biomechanical cadaveric study and clinical preliminary results with good results. Nowadays, the literature is full of paper on this topic about clinical data, technical notes, and systematic review. We have the confirmed by literature that the superior capsular reconstruction is restore the biomechanics of the shoulder, and from a clinical point of view, has a good results despite the donor side morbidity because we have to harvest the fascia lata tendon. And the problem is that when the tendon will tear, because if the graft tears, the results will decline. So we have an improved biomechanics and satisfactory outcomes, but this technique is a technical demanding procedure. There is a donor side morbidity because we have to harvest the autograft, and it's quite expensive. For this reason, literature, many authors developed different techniques in alternative to fascia lata, and especially with dermal allograft. But obviously, with the dermal allografts, we have a problem about the money because it's expensive. The allograft, usually dermal allograft, is from a biomechanical point of view less powerful in comparison with a tendon because it's thinner and the retear rate is higher. A possible solution may be the use of long head biceps tendon, the porción larga, and this technique may be described as a less technical demanding procedure because we have no donor side morbidity, even if we employing an autograft, and it's less expensive because there is a use only of 2 anchors or 1 transosseous tunnel. In 6 months, in literature, were published 3 different techniques with the use of the long head of biceps. As said before, the colleague that speech antes de mí, there was Boatsidis, there were Kim, and 6 months later, I published this technique. And so I'll show you the technique that was called the ABC technique. Obviously, the presence of the long head, the biceps tendon, used as an autograft is the conditio sine qua non, because if we don't have the biceps, we can continue with this procedure. I usually work in interscalene cervical plexus block guided with sonography and in lateral decubitus, and this technique needs only 3 portals: the posterior for the scope and the one anterior superior portal and lateral portal that are working portals. Now, Sorry. I hope that the video will work. I'll show you some steps of this technique. As I said before, I work in lateral decubitus. Now the camera is in the lateral portal. You see the biceps. The subscap was yet repaired. And then we have to cut as distal as possible the long head biceps tendon. So we maintain the origin to the glenoid. And then we can translate from anterior to the middle part of the humeral head. And we have to fix this tendon to the greater tuberosity. We have to clean the tuberosity with the radio frequencies, and we can remove all the scar tissue of the ruptured tendon. And with a motorized shaver, I remove also the bone, so to refresh the bone, to have a spongy, bloody bed to put the biceps. This is the technique to fix the tendon. I pass twice along the posterior border of the biceps the same wire. I prefer to use the tape because biomechanically the tape will distribute in a better way, in a better manner, the pressure on the tendon. And after prepare the posterior border, we have to do the same procedure for the anterior one. So we pass once with the suture passer, once time the sutures, and then we pass again. So we make a loop that is important, because if you pass only one way, the risk is that the wire will pull out from the tendon. After that, I use a knotless anchor in this case, and we fix laterally the tendon. And this knotless anchor is in peak, and it's quite really good anchor, because you can rotate the black knob, and you can control the tension of the repair. I put two anchors, one anterior and one posterior, on the lateral aspect of the humerus, and in the same manner I control the tension of the repair, pull attraction on the sutures. And so the tendon is fixed. After that, we can pass some sutures to make the side-to-side from the residual tendon to the biceps. And so we can close in a partial way the hole. Obviously, don't close the rotator interval, because otherwise we can have a restriction of the rotation of the shoulder. And then here we are closing the side to side with the residual calf and the biceps. And now I show you with the camera in the lateral portal the aspect of the new repair. And this is the tendon and the stability of the repair. I followed the patients. I was worried by the pain, so before publish this paper, because the biceps is the enemy of the shoulder surgeon, so the enemy to kill, to obtain a pain-free shoulder. So I checked the first 9 patients for 6 months to evaluate the pain evolution. The follow-up was of 6 months, and the VAS score was significantly improved in all the patients, and there were no difference between with or without subscap tendon repair. That was repaired in 6 cases. The operative time varied from 46 to 58 minutes. It depends if we have to repair the subscap. And I had no postoperative complication and no intraoperative complication. In no cases I performed the biceps tenodesis of the residual distal part. The Popeye sign was easily detected only in 4 patients, but in 5 cases it was covered by the subcutaneous tissue. So the advantage of this technique are inside the technique, because the long head biceps tendon is an autograft, so we have no donor side morbidity. As an autograft, is cost saving, is a tendon as fascia lata, so from a biomechanical point of view is superior to dermal allograft. It maintains its origin, and so it's vascular pedicle, so it is vital. From a technical point of view, is yet fixed medially to the upper part of the glenoids, so we have no needs to fix. And for this reason, the surgery is easier or less demanding, and reduce the operative time and consequently reduce the cost. Its lateral fixation do not present particular skills, because the shoulder surgeon is obviously more confident to fix a tendon into the greater tuberosity. The disadvantages of this technique obviously are the anatomic variation of the interarticular portion of the long head biceps, the congenital absence of the tendon, that is a very rare condition, and in case of partial tear or complete rupture that we can find as a consequence of rotator cuff tear. So the techniques were described, but the results were initial promising results, but the follow-up is too short to make a definitive conclusion. Thank you for your attention.